spinal cord injuries, spinal fracture care, and then a discussion about how we might look to manage the older or frail patient, and then a summary. Thank you, Sarah. So to start with, I thought, goodness, this is half an hour to do spinal fractures and spinal cord. But then when I actually started thinking about it, while the kind of drama around them is different, the way we manage them and the way we think about managing them is fundamentally the same from an inpatient setting. So we're looking firstly to protect the cord. First and foremost, that's what we want to do. We're protecting it either from further damage or from new damage. Understand the injury and its stability, decide surgery versus no surgery, consider the use of orthotics, prevent secondary injuries and manage risk, meet the patient's rehab and discharge needs, and then the big question, what to do with the older or frailer patient. Thank you. So the spinal cord injury side, we have done quite a lot of work at UHCW on this. So we mapped all the needs of the spinal cord injury patient. It's highly complex, and this shows really everything you need to think about with a spine patient. Actually, when you look at it, all of these things are relevant for the patient with a spinal fracture as well. So we need to be considering respiratory function, tissue viability, soft tissue management, stomach and bowel, eating and drinking, and thromboprophylaxis. Thanks, Sarah. Next slide. Lovely. So at UHCW, several years ago, it must be 4 or 5 years ago, we recognised really we weren't very good at consistently managing patients with spinal cord injury. There wasn't any area that we could specifically address. Different times, it was different aspects of their care that we were poor at delivering. So what we came up with and have developed over those years is the traumatic spinal cord injury care pathway. This is put into place with all our spinal cord injury patients, trauma ones, and is used for the non-traumas in an adapted form. It guides all members of staff around what they should be doing with these patients, from the nursing staff through to the doctors and the timings that we expect. It includes the drug management that we would want put in place, and then includes tip lists of what the trauma coordinator should be looking at in the first 1 to 2 weeks of management with the patient. It also includes the documentation for the nursing staff to record their delivery of care. It also includes information about autonomic dysreflexia and handling the patients. This we find is running reasonably well in the trust. It's guided our training. What we need to do now is actually get it onto the guidelines. And the reason it hasn't got to that point is the Midlands Tri-Network decided that they would be doing a similar piece of work, some guidelines around managing and best practice care. And that was finished fairly recently, just pre-COVID. And that's now on the trauma network. So now I can pass that through with knowing that there isn't anything major to be changed. So that pathway is followed for all our spinal cord injury patients. Thanks, Sarah. So if we run through the areas of concern that we'd like addressed, the first area, protect the cord. This is what we're planning to do with either the fractured patients or the spinal cord injury patients. This is where the first plan will always be fairly restrictive for the patient. They'll come into ED. The first things the neuro or the spinal team are likely to say is flat bed rest, collar for immobilization if it's a cervical or a high thoracic fracture, log roll or alignment roll. This is photographs we have that are part of the spinal cord injury pathway, but this is how we would handle. So it's the method recommended by MASCIP. It's a 3 up, 3 under technique, and you'll notice from the staff's hands, when we're talking about a 3 up and 3 under technique, you've got 3 hands up over the top of the body, and then you've got 3 hands under at the lower end of the body. This is a log roll technique. It's led by the person at the head end, and they direct, patient is taken over into a log roll position, care is delivered, And in this particular instance, this patient is returning to an alignment side lie, which is for pressure relief, and left in that position. So protecting the cord is the first and foremost thing we want to do. With this, we're working at the moment to try and work with the trust around this technique, and it may be different in different trusts, but we can't find anywhere that has this as part of their mandatory training. The trust here say it should be purely taught on the specialist wards, but actually we're finding these patients all over the building. Patients require log rolling in medicine, they require it in care of the elderly. If a patient falls on cardiology, they will require log rolling, and you need staff to know it. So we are in the process of working with the trust about making this a role requirement. It's likely to be a role requirement for all band 6 and above nurses, all therapists, and then looking for this to be a role requirement in areas like radiology, oncology, those sorts of specialist areas. We'll be doing some training videos around this, and these hopefully will eventually be available on the internet. But again, this is the way we will be teaching it. We will come up with the UHCW approach, and would be quite happy to spread it outwards, but you'd have to get it through your manual handling teams. Thank you, Sarah. So areas 2 and 3 around immediate planning and then decisions around surgery. The one thing we would say from the inpatient side of things is the diagnosis and planning should be based on the clinical picture as well as the scan findings. Quite often decisions are made off of scan findings only, and what we tend to find is the plan therefore is the same for your 25-year-old as it is for your 89-year-old who also has rib fractures, comorbidities, and that's fine, but it causes real problems with managing other issues, and we find that the decision making drifts. So UHCW has a spinal consultant rota which has neurosurgeons and TNO consultants on it. As I said, the immediate planning is likely to be bed rest, immobilization, and MRI. They have a weekly spinal meeting, and some of you may have experience of referring patients to that. That's where they meet as a peer group and plan. It is a complex spinal meeting, but we are finding it tends to now be used to reassure in a lot of the routine management planning, and that's something I think we at this end need to address. The problem with it being once a week, it's really unfortunate if you were then to have your injury on the Friday, because you're now looking at a week immobilized on bed rest and potentially having an unnecessarily MRI while we wait for the meeting the following week. The interesting point around all of the medical management side of things is actually the longest period of time for patients with spinal fractures is getting the plan. Getting the average spinal fracture patient up and moving after the plan is straightforward, and if they've been operated on, we can normally get them discharged within a couple of days. So we can remove the front end decision making issues, then we would be looking at shorter stays and reducing risk for these patients. So one of the things around the medical management side of things that we're looking at currently is the overuse of orthotics. We also need to be considering how we link with our TUs and our LGHs, which patients really need to come to us and which ones could stay at the local TUs if they had nice, clear planning. And then one of my big questions really would be, why are we putting older patients with dementia through the trauma of an MRI to determine ligament stability if our plan is always going to be an orthotic and mobilize? These are the sorts of things that we need to come up with some planning and some ideas across the network for. Thank you, Sarah. So at UHCW, we tried to standardize the use of orthotics. We found it very difficult to be constantly training staff around different orthoses. Even if you change the color of some of them, then it becomes something they're not competent to do. So we now currently use the Miami J Select, which is the top left collar. This is a adjustable one, so it should fit 90% of the population. The extremes really are the very, very small, frail, who we would probably use a Miami J pediatric collar with, or the bariatric end, or the very thick stout neck end, which again, Miami traditional collars can fit those patients. But what we've been able to do with bringing the Select in is that each of the core areas now have their own stock that they manage, because you're using one collar to fit most of your patients, so you don't need to be holding lots of stock. And then they adjust them, and if we come round and we find for whatever reason it's not the greatest fit when we notice them, it's very easy to adjust without having to totally use a new collar. So from a cost implication point of view, it's a nicer collar to use. They also come with spare pads. Generally, the patients tend to find them more comfortable than Philadelphia collars. So that has been a successful launch, and we've been using those for nearly 2 years now, with really no problems. The main thing with the collars are that people have to put them on firmly enough. They're actually more uncomfortable when they're on loosely, and the patient really shouldn't be able to move their heads in them. You'd be amazed as they watch you walk through the unit how much people can move their heads in most collars. So if we're looking at a lower cervical or a high thoracic fracture, we'd be looking to use the Miami J with extension, which is the one the lady has on. This is quite useful down to T5, stops us having to use the full body CTLSO, which is just an awful piece of kit for most patients and makes discharge very complex. This is a nice piece, pretty easy to get on and off, and quite often what we have is that they just wear the collar in bed and they only go into this with the extension out of bed, far more comfortable for the patient. The gentleman in the middle is wearing an MKS Osteoflex brace. This is a modular brace, which is very useful with the older patients, the frailer patients, because it's measured specifically for them and the heights are all set, particularly useful with kyphotic patients. It's slightly harder to get on and off, but normally we can get that taught to carers or to family, and that's our kind of secondary brace. Normally we would use a leopard brace. They've actually recently gone out of stock, so we've changed very recently to the one on the bottom right, which is the Aspen. Nice brace, very, very comfortable. So we're just getting to grips and changing our paperwork around this. But we will have patient information leaflets. We will have training programs for staff. It's very nice to get on and off, and it's actually easier than the previous leopard brace to teach people. There's also a lot less Velcro for other people to dismantle. Quite often you will find your braces in all sorts of conditions if somebody unfamiliar with it has tried to remove it, and then you basically just need to rebuild it. So this is a much nicer one with very clear sections that you remove. So we use these, and then we're able to teach across the departments. All the physiotherapy and occupational therapy staff in the hospital are trained on how to get people in and out of these. We do as much training as we're asked across the nursing staff, across the wards, and then it's a team effort in making sure the families know how to help people with these. What we have with the orthotics is, in Coventry specifically, we found that discharge can be quite complex. So patients in the collars, we've actually got care facilities and care teams that will go into homes who are familiar with this and know how to deliver the care. And that's made discharge delays a lot shorter, because we were finding you have to bring in another care agency, show their staff, you have to get a certain amount of their staff trained up. If it's something that the staff are familiar with, then we have no problems. In addition, with the TLSO braces, if you can't get somebody to go in and deliver care, actually these patients sometimes need to go to non-weight bearing placements, because the braces come off at night to give the skin rest. And that makes the patient, in effect, a non-weight bearing patient, because they need assistance to get the brace back on. This changes their pathway route out of the building quite significantly. Collars, it doesn't matter. The collars are on all day. You just have to deliver collar care once a day. Doesn't matter if that's lunchtime, first thing in the morning, mid-afternoon. It could be a family member coming around and having a cup of tea and then delivering the collar care then. The braces are more complicated, because if you can't get out of bed, and get up for your breakfast until somebody comes and helps you into it, then you're stuck in bed. It's very rare for patients to be able to put the braces on independently, and you really shouldn't be encouraging it, because you pretty much have to be a contortionist, which kind of eliminates the reason why we're using the brace. Thanks, Sarah. So the preventing of secondary complications, bit like John MacArthur was saying with the pelvic fractures, a lot of the risk is around the amount of time that they're in bed, and we need to be eliminating that. That picture there is a pretty nasty occipital pressure sore. That's from a previous format of collar, and that patient hadn't had effective collar care, and it's only really when you shave the hair back that you actually see the extent of what's going on. So if anybody's on an extended period of bed rest in a collar, they ideally should have an Ossian back, which is a soft pressure relieving back to the collar. And they should definitely be having collar care delivered at least once a day with full checks. That might be with log roll, or it might be that the patient can roll themselves. The log rolling side of things is useful, but please don't ever think anybody has to go into the community with log rolling. I've had a few discharges held up by that because people think they have to be log rolled in the community. If the patient is walking, able to roll themselves about in bed with the collar and sleep normally with the collar on, they can position themselves in order for collar care to be delivered. It doesn't suddenly need head hold and all panic. It's just a pragmatic view. From a respiratory point of view, the bed rest is a big issue to us here, because often if we've got elderly fallers, they will have some associated thoracic injuries. Even if they don't, they've probably got comorbidities impacting, and lying somebody flat for any length of time is not good for lung expansion or cough effort. With the spinal cord injury patients, we would be doing spirometry on a daily basis to measure. It's hard to do accurately in lying, but our reasoning is that if we can baseline them, then we can monitor the baseline. So while our volumes may not be exact, you can see a change in their ability, and we would be using prophylactic cough assist with the spinal cord injury patients who have got a reduced cough effort. From an orientation point of view, bed rest is a nightmare. Elderly with an element of dementia or even just some delirium, and you're lying them flat on their back, they're not going to be that compliant. If they are compliant, they're going to become very disorientated very quickly. It's hard enough for the younger ones, and when you're explaining to them lying on their back, orientation-wise, it's very difficult to know what's going on in your room. So obviously we have the glasses so that they can see who's coming into the room. But if somebody is flat on the back with a collar, it's always nice, and you feel a little odd, but to peer over and let them see your face. Otherwise, you're sort of a distracted voice coming from their right or left-hand side. Strength and conditioning, we know any period of bed rest, there is a rapid loss of muscle mass and power. And in the elderly who perhaps were just about coping at home, once this is lost, that is very hard to regain. So you're potentially looking with an extended period of bed rest at the result being this patient is going to go into some sort of care facility if you lose their baseline level. Nutrition and hydration is a big thing for us as well. And we get our dietitians involved with all our spinal cord injury patients, but that's something to consider also with the spinal fracture patients. Very hard to swallow, lying flat on your back. The elderly are likely to have a porous swallow anyway. Positional difficulties, so the alignment side lie that you saw the picture of before, even that 20-degree tilt to the side with those pillows down the side actually allows people to start controlling food and drink in their cheek rather than it being going straight to the back of their throat before they're able to control what's going on with it. There's also a loss of appetite, and we need to be thinking about any supplements they require. And I've put there all things bowel. The minute you lie people down, particularly the elderly, everything is going to slow down. We've probably got them on pain relief as well, which isn't going to help. Very hard to open your bowels lying flat on your back. And then you also have the dilemma of, do we use slipper pads? Are they just using the pads? How are we doing this? Because if they're a lumbar fracture, you're not putting a large pan in underneath them. And all of those things, those systems all start to slow down and become sluggish. Thank you. So from a rehab discharge plan, we need to be looking to return them to a level of function required for safe discharge. That's got even tighter since the COVID introductions. We used to be able to push on and try and get back to what is often termed baseline function. We may not even have time to get to baseline function now. We are just looking at safe discharge and then hand over to the community services. That's hard for staff to do because we actually know the community services generally aren't out there or reactive enough to the needs of the patients. And if we're sending them home at a lower level function, are they going to progress off of walking aids or downstairs existence, those sorts of things. So we need to be getting rehab started as soon as possible. For the spinal cord injury patients, obviously that's a very early referral to the spinal cord injury centres. It's demonstrated in the GIRF document from 2019 that is one of the biggest holdups, is actually getting patients referred. Part of our pathway is getting the patient referred and onto the database within 24 hours. That makes the units aware of the patient, and then we can start sending them the information and pushing gently to try and get the transfers. The GIRF indicates that the longer patients are in acute hospitals, the poorer the quality of long-term outcome from them, even from a spinal cord injury centre. We need to look at who's going to deal with the wearing the orthotic. So I've already told you of all the issues. How do we do collar care? Who's doing the donning and doffing of the braces? One of the big things we also need to look at is the follow-up requirements. We quite often get the early plan, but actually, particularly at the TUs, what is the escalation option for you? If the patient who is in the brace that you've been told to put on them is having increasing pain or neurological deterioration, what's happening? Who are you referring back to? How quickly do you need to refer back? Do you refer back with a CT scan? Do you refer back and wait instructions? It would be nice to get that level of planning to you and that reassurance to you. Also, with a lot of the spinal patients, the spinal fractures, the elderly, there might need to be additional referrals on, because actually the root of the problem is medical issues leading to falls, and we need to be addressing those. They need to be recognised as something that needs addressing, so referrals to your local care of the elderly team or medical teams, and then who's going to follow them up. Do we want them coming back here? So I've had conversations with consultants before. The elderly 90-year-old from a nursing home that they put in a collar because they are never going to operate on that neck. Does she need to come back at 8 weeks for them to rescan her, which she won't understand? It requires ambulance transfer. She's going to be out of the home for sort of 6 hours, probably missing food and drink. It's all messy. The consultants aren't going to do anything in clinic because the patient is likely to turn up on a trolley. They're not going to assess. So do we need to bring them back? Should we be making clearer plans that the collar is on for 12 weeks? You scan, unless it looks terrible, then the collar comes off. Or is it collar for life? Is that the sort of conversation that needs to be had? Or indeed, should we have really put them in a collar at all? And that's part of the planning. Sometimes the patients who come back, the younger ones, will need referrals on. There's no point the ward staff referring them from the wards, because you're looking at the collar or the brace being on for 6 to 8 weeks, could even be 12 weeks. So at that point, is somebody making referrals on for physio referrals from clinic? As a major trauma centre, we have to consider these sorts of things when we do the prescription for rehabilitation. And sometimes we will indicate on that the consideration about physio referrals, we will indicate that to the GP in case it's missed at the clinic side. Some of these will be fractures in young, fit, athletic people who want to return to sport or activities where they need to be strengthened up, and we need to make sure that they're getting the follow-up rehab they should. The rehab prescriptions are part of a national requirement for us as a major trauma centre, and the trauma units are encouraged to continue them. These should be arriving if we're transferring patients back to your units for you then to action and then repeat at the point of discharge. They should reflect the ongoing needs of the patients at that point. A lot of the young patients, we just don't do rehab prescriptions on if they're discharged home. just because we don't know what their needs are going to be after that point. Thanks, Sarah. So the spinal fractures in the older patients are a big problem, and nationally I think it's recognised as a large problem. There's a lot of work going on. Caroline has talked about research around the use of the collars with some of the odontoid peg fractures. There's various things going on around that. We need to recognise the need for a pragmatic approach to these cases. The management is very likely to be conservative, regardless of any enhanced scanning. They don't want to take these patients to theatres. So why are we doing that enhanced level of scanning? Some injuries indeed will show up and often show up, but actually it's very difficult when you ask somebody to review it as to whether they're subacute or may even be chronic, and are often incidental findings on the scan. They've come in, they've fallen, we scan them, we find this, and then we have to unpick how long it is, and they may actually be walking around at home with this for 3 or 4 weeks with no risk or no restriction. We can't wait, particularly with the elderly, for a once-a-week spinal meeting discussion. We need some plans in place earlier than that if we are actually to get some good results. Plans need to acknowledge the risk of the immobilisation and relate to any other injuries or comorbidities. And then we need to recognise with the elderly that discharge home or discharge to their previous level of independence is dependent on early return to mobility and function on the ward, similar to what John MacArthur was saying around the pelvis fractures. Thank you. So my final slide, London Major Trauma System have just republished their 3rd edition of their management of the older patients, and they support the arguments around the older patients. So they are likely to be less compliant. It's very difficult keeping a dementia patient flat. It makes no sense to them. It's very difficult just keeping them in chairs. So why are we doing that? We need to recognise the associated risks, and the most important thing that they come up with is we need early, prompt, senior clinical decision making, and we need to minimise the time that they're under any handling or positioning restrictions. The most important thing is that these conversations are had with the patient or their carers or significant others. There is always risk, and there could well be ligament damage, but why are we scanning to check there's ligament damage if we're not going to change our plan? If we have discussions with the families and say, look, there is a fracture, there's probably going to be ligament damage, but our plan is going to be a well-fitted collar, we're going to get them up, we're going to get them moving. There is a small risk of spinal injury, but there is a greater risk of chest infection, UTI, loss of appetite, all of the things that are probably going to cause them to deteriorate rapidly medically. If that conversation is open and transparent with the families, we normally find that the families completely understand and would rather their 90-year-old was given a chance to get up and get moving quickly. The other thing I took from the London Major Trauma System is, and we've asked them for them, they've got 4 main pathways for managing, and we would really be interested to see how this looks. Wondering whether this is something we could look to achieve across our network. So we're looking levels 1 and 2, you're probably looking at these being kept at their local hospital with some really good clear advice, some clear plans. Levels 3 and 4, the unstable fractures requiring surgery or the highly unstables requiring urgent intervention. Obviously, then we decide what the route is to get them over to us rapidly. But I think there's a piece of work here where we don't need to be moving these patients in order for them to come over here, be scanned, and the decision to be conservative management anyway. It's very difficult to get them back to their own local units, and then discharge planning can be quite complex from a distance. So we are interested at UHCW in tackling this, and it would be a nice piece of work to work on with any interested parties. So my final slide is looking at the areas I suggested at the beginning that we needed to consider, but with some slightly different wording. So first and foremost, yes, we're protecting the cord. The second, we want prompt and considered medical planning, and we want timely surgery where it's required. We need to consider the appropriateness orthotics. There's a little bit of creep at the moment, and we're getting more and more, oh, brace for comfort. I can assure you these braces are not comfortable. The patients do not find them comfortable. So why are we even introducing that complication into the picture? We want to be preventing secondary injuries and managing risks. We want to meet their rehab and discharge needs as soon as possible to return these people to their own homes. And we need a pragmatic approach to the older, frailer patient. My final point, is it time for some system-wide pathways work? Thank you.
Thank you, Nicola. I think that was amazing. We don't realize how much work is done behind our backs and how much effort is put into actually getting these patients back on their feet after they're going from the hospital or they are discharged from the acute wards into the back system. So from that point of view, yeah, I think we don't appreciate enough the weeks and months of rehab that you're putting into those patients. Regarding the braces, what is the realistic period an elderly patient will look at spending with the braces on in the community? We're talking about 8, 12 weeks, or we're talking 6 months plus?
So the collars, your minimum length of time if an elderly patient leaves us will be 12 weeks. Can be longer, because once you've started down that track, you then want to be showing some healing in the neck. With the back braces, the younger patients, it will be 6 to 8 weeks. And in the elderly, it's around the 8 to 12 weeks. But to be honest, we normally find that they've all made their own decision. When they come back to clinic, they've decided that they're not wearing it anymore. And that's and we've had no issues with anybody having any issues having removed their own braces. But yes,
so it's a kind of a patient-led system.
I know, completely.
Interesting. That's what I didn't realize, because sometimes we see people stuck on hospital beds for months in a row, and
there has been some issues, and that's why we've got these care teams that now are able to. I think a lot of hospitals have a difficulty getting who is going to put the braces on and off, who is going to do the collar care, and if you can't resolve that, then it's not safe to discharge them.
Do we have a unified system of collars? Well, collars I know we don't, but for braces during our through our network. I know for collars wise, for example, you guys are using Miami J, we're still using Philadelphia, and every hospital is a bit different. But even for braces, you're not using the same types as the trauma units around.
Not necessarily. You'll see ours when they come back if they're transferred as inpatients. Most orthotic departments in hospitals are now externally contracted, so it'll be partly down to who that company deal with. Ours are fairly open and deal with quite a wide group of companies, and we've been able to direct towards what we want. But you may well find that yours at your hospitals are linked to certain companies, which isn't the best way to be choosing things. The most important thing is that you get consistency of understanding and problem solving for your braces.
Yeah, because I presume at the end of the day, you would know most of the types of braces, but you probably don't know absolutely all of them. And the same for our physios and our nursing staff. They won't. A patient potentially will be discharged with the type of brace they've never seen before.
Yeah, absolutely. And this is where doing something like some CETN network pathway management, this is where we could look to support each other on this.
Sorry. Yeah,
and most definitely if we introduce some log rolling training, because I'd be intrigued to know who does your log rolling training in your trust, because we can't find any national systems for it or anybody who will train the trainers. So we're going to come up with our own and peer review it, get the surgeons to agree, and come up with the UHCW training program.
Very interesting. Yeah, that's another point. To be honest, I'm not even sure we have a proper log roll training.
No, most of us have learned it as we go along, but of course these days you need competencies. So that's the route we're taking. We will have a program which we're quite happy to share.
Lovely. I'll be very interested to see that program once it's up. So please do keep in touch. Oh, I'm being told that we do have some log roll training in house in catering by the manual handling department.
Marvelous. I might give them a ring.
Yeah, thank you, Louise. I wasn't honestly aware of that. That's a miss on my part.
You just got to do we back. Yeah, a lot of these things are department specific. So on our neuro wards, we do our own. On our TNO wards, we do our own. It's when you start moving out into more vague areas that nobody has it.
Yeah, perfect. Thank you ever so much. Lovely, Nicola.
Thank you.
Appreciate your interventions, and I'm sure we'll see more of each other in the future for similar subjects.
Great. Thank you.
Thank you ever so much.
Andre, you're muted.
Sorry. It's my kids. So I was talking to myself. Yeah, I was saying we're slowly getting to the end of our day, and in my opinion, it was interesting. There's lots of points to take home. Not necessarily things that will massively change the practice, but mostly ways to interact with others and places to look for information. As far as I can see it, there were a few very good speakers. Well, all of them were very good speakers, but every single one of them had points that we can take on and develop in our trusts. And yeah, I think that is my take-home message from the sessions today. I would like to see future sessions on the same category of subjects, and I think our colleagues will be able to provide us with lots of suggestions for what they want to hear next. And I think it will be for the leaders, for us to see if we can organize other sessions in the future, as we were discussing at the beginning of the meeting. The links for feedback and certificates have been posted by Caroline and Sarah. I do apologize, but apparently my chat function doesn't work.
Okay.
And I also want to apologize for all the system problems we had today. It does happen. It's not necessarily in our control when we're working on different systems for different trusts. And yeah, I think that is it from me. Does anybody want to add anything at the end?
Just from me, again, just a reminder that the feedback link, Caroline and I have posted, but all the information is also on our network website, which is mcctn.org.uk, under trauma, and you'll see the previous session on there as well. So please do take the time to complete the feedback, otherwise we won't know what to do as priorities for the next one, which we will do. And I've attached a Word document, attendance certificate, mainly again because this system, although it allows you to download attendance lists, it doesn't add the emails.